Hello, everybody, and welcome to this webinar, Current Perspective on Management of AL Amyloidosis. My name is Eli Muchtar here at Mayo Clinic, Rochester, and I'm happy to you all join me today on this webinar. This webinar is being hosted by the International Academy of Clinical Hematology, and I would like to thank at the beginning of my speech Professor Nagler and Professor Modi for giving me this kind opportunity. The webinar will be approximately 45-50 minutes in length, and we'll discuss the management of the complex management of patients with AL amyloidosis. You will be able to submit questions through the question mark icon throughout the webinar, and I will be happy to answer those questions at the end. These are my disclosures. We have several learning objectives in this cast. One is to define the treatment goals in AL amyloidosis. Our second goal is to discuss the choice between autologous stem cell transplantation and versus standard intensity therapies. We'll also discuss toxicity management as well as the management of relapsed refractory AL patients. My first slide is to give you some disease overview to understand better our presentation. AL amyloidosis is a plasma cell clone which reside in the bone marrow space. Those cells secrete immunoglobulins, including an axis of free light chains. Those free light chains can then deposit as amyloid in tissues and organs, and they can affect organs such as the heart, the kidneys, the nerve, liver, GI, and other organs. The affected organs are the source of symptoms in this disease and are the major determinant for prognosis. Control of the PC clone is mandatory in order to halt further organ damage caused by the amyloid deposits. Moreover, without an organ response, survival is unlikely. Our goals of therapy are to improve the organ function and to extend survival. As we said in our previous slide, this is by targeting the plasma cell clone. As patients that oftentimes are very symptomatic and with significant organ dysfunction, response should be rapid and deep. And we can say that treatment of AL amyloidosis is a race against the clock. Moreover, patients are quite symptomatic and we need to provide them symptomatic relief. Even if patients achieve an hematological response, meaning a reduction in the circulating light chains, organ recovery usually takes at least months to years since that time. Moreover, when patients are receiving therapy, symptom burden does increase with therapy. We have 4 hematological response criteria which were formulated by Palladini et al. In 2012. These response criteria clearly put patients in different survival curves. The best response that one can achieve is a complete response, which is defined by achievement of negative serum and urine electrophoresis immunofixation and a normal FLC ratio. This is our preferred response goal. However, at times, this is not easily achievable, and therefore, very good partial response is an acceptable alternative as a response goal. Very good partial response is defined when the DFLC, the difference between the involved to the uninvolved light chains, is less than 40 milligram per liter or 4 milligram per deciliter. Our management approach is risk adapted. One should consider the organ impairment when choosing therapy. As such, younger and fit patients can receive more intense therapies, while fertile patients have poor treatment tolerance and increase in early death. So how we define frailty in AL amyloidosis? Well, we don't have frailty scores being examined in this patient population. However, we can use short-term survival as a surrogate for frailty. When we use that, we know that age, number, type, and extent of organ involvement are major determinants of frailty, as well to a lesser extent pre-existing comorbidities. Let's look at the effect on age on survival. This is Mayo Clinic data from patients diagnosed between 2000 and 2015. Over 1,500 patients are in this cohort. One can see that in unselected cohort, patients less than the age of 65, represented here in the red curve, had much better survival than patients 65 or older, which are represented in the blue curve. However, age is a major component in determination of stem cell eligibility. So if we're restricting our analysis to a non-transplant patients, we can see that still there is a gap in survival between patients younger and older, although the gap is narrowing. Let's look at the effect on the number of involved organs on survival. This is a Mayo cohort of nearly 600 patients that had AL type that was verified by mass spectrometry. The time period is 2008 to 2015, and you can see that the median overall survival for this patient population was 44 months. When the survival was divided between the number of organs that were involved, one can clearly see that the survival declines with more organs being involved. But it's not only the number of organs involved that really determines survival. Let's take two examples. For example, heart involvement. When heart involvement, which is the major organ involved in AL amyloidosis, is present, it doesn't really matter if it's an isolated heart involvement or heart as part of a multi-organ involvement. The survival is nearly identical. However, when you look at patients with kidney involvement, then we see a different picture. Patients with an isolated kidney involvement have a much better survival than patients that have kidney involvement and at least one more organ. Overall, we can say that heart involvement is an important prognostic factor in this disease. Therefore, it is not surprising that the cardiac risk models in AL amyloidosis are quite powerful. We have three models that are based on cardiac soluble biomarkers in this disease. The first model is the Mayo 2004 model, which utilizes troponin T and NT-proBNP at certain cut points and divides patients into three distinct groups. In 2015, a European collaboration group proposed a modification for the Mayo 2004 model in which the patients with a stage 3 were subdivided into two subgroups when using a higher NT-proBNP cut point at 8,500. In 2012, there was a revision for the Mayo model, which utilizes troponin T and NT-proBNP at different cut points than the 2004 model, and also adding DFLC as a marker for disease burden. I would like to point out that although we're using troponin T and NT-proBNP in all of these models, as well as DFLC, one can use different types of cardiac biomarkers, such as troponin I, high sensitivity troponin T, and BNP, and you can refer to this publication for further information. These are the survival curves using the same patient data set for those three models, and one can see that those models are very successful in dividing patients into distinct survival groups. Before we go to the treatment portion of this talk, I would like to emphasize that typing is a crucial part in determination of disease course, prognosis, and treatment. One cannot assume that the presence of a monoclonal protein and amyloid equals AL type. This is not necessarily true. There are several typing methods that are available and are listed here. Well, where mass spectrometry is the current gold standard, but there are other acceptable alternatives. Now we move to the management treatment of patients with AL amyloidosis. The first question that need to be asked when we approach therapy is whether the patient is stem cell transplant eligible or ineligible to transplant. Patients that are stem cell transplant eligible, at Mayo Clinic, this is represents approximately a third of our referral population. Patients that are stem cell ineligible, we need to be more easy with our therapy, using standard intensity therapies or even low intensity therapies for the patients that are quite frail. These are the eligibility criteria for stem cell transplant here at Mayo Clinic. This is a list of the seven major ones, and one can see that 4 of them are directly linked with the cardiac function. Once again, highlighting the importance of cardiac involvement, both on survival and frailty of these patients. In comparison, this is the Boston University group stem cell transplant eligibility criteria. They, to some extent, differ from the Mayo one. However, they still quite largely rely also on the cardiac function. So among patients that are eligible for stem cell transplantation, how to choose therapy? This has been a matter of perspective for many years and evolved over time. We can say that the advantages of stem cell transplantation are the high response rate achieved with this type of therapy, as well as durable responses. The disadvantages of stem cell transplantation are the short-term morbidity and mortality that can be quite significant. Moreover, this type of therapy can be offered only to selected patients. Let's look at the data on the depth of response achieved with stem cell transplantation. And we will look at the complete response rate. As we mentioned, this is the best response that one can achieve. Well, this response rate actually are dependent on the conditioning dose. These are data from Boston University and Mayo Clinic, the 2 major groups that publish on stem cell transplantation in AL amyloidosis. One can see that if a full dose Melphalan was given to those patients, the complete response rate ranged between 43% and 53%, where patients that receive a reduced dose Melphalan, either because of their frailty, kidney function, or other reason, the response rate, the CR rate, has declined to 24 to 37%. We can also see that the survival of patients is improved when they were able to receive the Melphalan 200 milligram per meter square. The Boston group reported a median of 8.4 years, and the Mayo group reported 4-year overall survival of 86%. But it's not only the depth of response that we need to assess, but also the durability of response. This is a Mayo data on patients that survived at least 10 years from the time of diagnosis, and we looked at the need for a subsequent line of therapy. At 10-year mark, all patients survived, and we can see that at that time point, 47% of patients remain treatment-free. When we break it down between stem cell transplant and standard intensity therapies, we can see that patients that receive stem cell transplant were 58% of them were treatment-free at 10-year mark, whereas compared with 36% in patients that receive a standard intensity therapies, this translates into a delta of 22%. So definitely stem cell transplant is associated with a more durable response than standard intensity therapies. So what are the arguments against stem cell transplantation? This was for many years the main argument against stem cell transplant. This is a randomized controlled trial which compared Melphalan-Dexamethasone, which is a standard intensity therapy, compared with stem cell transplantation. It was done in the years of 2000, 2005, and recruited 100 patients. This randomized controlled trial actually showed that patients that received standard intensive therapy had an improved survival compared with patients that were receiving the stem cell transplant arm. But there are very major limitations to this study. This was in the early experience with stem cell transplantation. At that time, there was no really good patient selection. For example, of the 50 patients that were enrolled into the high-dose Melphalan, only 37 patients actually proceeded with the transplant, and the remaining just had mostly early death, which precluded them from enrolling on that. This resulted in the day 100 transplant-related mortality. The rate was high, 24%. Let's look what's going on in North America between 1995 and 2012. You can see that this is the rate of early mortality divided by times. This is 1995 to 2000, 2001 to 2006, and on the gray curve, 2007 to 2012. One can see that both 30-day mortality and 100-day mortality declined significantly with time. From day 100 mortality from 19% to 11% and eventually 4%. So we are clearly doing progress with selecting better our patients to this procedure. Moreover, patients that were had transplant in centers that had 4 or more transplants per year had a day 100 mortality of 3% versus 7% in centers that had less than 4 transplants for AL per year. This highlights the importance of center experience in making better outcome for those patients. There is also the question of induction chemotherapy before stem cell transplant. This is data that was published by Lisa Hua from our group, and she looked about the impact of induction chemotherapy on the response following transplant. She divided patients into 2 major groups. Those patients that have a baseline bone marrow plasma cells 10% or less, and those patients that have higher bone marrow plasma cells of more than 10%. For those that have the low tumor burden with a low BMPC, there was really no change in response rate, whether the patient received or did not receive induction chemotherapy. But the picture was different for patients with more than 10% bone marrow plasma cells. Their overall response rate was better, including almost doubling of the complete response rate. I would also say that we should consider providing induction chemotherapy for stem cell eligible patients if there is an expected delay of more than 1 month to transplant. As we mentioned before, amyloidosis is a race against the clock. We don't want the patients to be with a further deterioration in their organ function. Another interesting question is, if a patient achieves a complete response to induction chemotherapy, should we proceed at that time with stem cell transplantation? Well, this is an unanswered question. We don't know if a complete response following induction and complete response following transplant is similar or different. However, given the morbidity and mortality associated with stem cell transplantation, and if a patient truly achieves a complete response, it's probably better to observe him rather than proceed with a stem cell transplantation. However, at that time point, I will collect stem cells for the potential of future transplant. The only patient population that I might consider proceeding with stem cell transplantation, despite achieving a complete response, is those patients that are more likely to relapse early on. This includes patients with high-risk FISH genetics, which are uncommon in patients with AL amyloidosis, or patients with exceedingly high bone marrow plasma cell count at the time of diagnosis. If you want to discuss some toxicity management with stem cell transplantation, we need to start with the process of stem cell mobilization. During that time, patients can experience significant toxicities. This is a list of the major toxicities, and that includes tachyarrhythmias, thromboembolic events, weight gain due to fluid retention, bleeding, acute kidney injury, hypertensive crisis, or hypertension. We know that the most vulnerable patients during stem cell collection are those with cardiac involvement, autonomic involvement, or multi-organ involvement. Our recommendation in this patient population is to have the G-CSF as a mobilizing agent, giving as a split dose twice daily rather than once daily. We recommend monitor daily weight and diarise the patients if they have a significant weight gain. We try to avoid chemomobilizations in patients that are failing to mobilize with G-CSF, and we know that plerixafor is well tolerated in this patient population. Patients can experience significant toxicity during transplant. Let's discuss the major ones. First, cardiac arrhythmias. 25% of patients that have Holter monitoring before transplant will have an evidence for non-sustained ventricular tachyarrhythmias. This was shown to be associated with a worse short-term survival. But overall, after you adjusted to the cardiac stage, this was not longer remain valid. Therefore, patients that have non-sustained ventricular tachycardia before transplant, that will not be an exclusion from transplant. Patients during transplant can experience arrhythmias. Half of them will. Most of them are low grade, but in 10% of the patients, they are quite significant, grade 3 and 4. It is unclear if primary AICD implantation will be of benefit to patients, even those among that are considered to be high risk for sudden cardiac death, and a decision should be done on individual basis. Another toxicity that can be encountered during transplant is worsening heart failure. Approximately 5% of the patients will have a decline in ejection fraction by more than 10%. This increases their day 100 mortality. The reasons for heart failure in this patient population during transplant, there are many reasons, as you can see, such as medications, electrolyte imbalance, arrhythmia, fluid overload, and infections. Those patients need an ICU admission to manage their heart failure and to correct the correctable reasons for the heart failure. I would like to emphasize that those patients, unlike other patients that experience heart failure, will not benefit from the use of beta blocker or ACE inhibitors for the heart failure management, and those agents should be avoided. Syncope can also occur in patients during transplant, and once again, the reasons are quite large in number. Patients can have syncope due to a cardiac reason, autonomic neuropathy, intravascular volume depletion, which are quite common in this during transplant due to poor oral intake, diarrhea, overdiuresis, GI bleeding, sepsis, etc. Drug toxicity can also cause syncope. Therefore, we need to pin down the cause and treat accordingly. I would also say that if a patient has evidence for sustained ventricular arrhythmia, then secondary AICD implantation should be considered. Another toxicity is end-stage renal disease following transplant. This is a Mayo data looking at approximately 400 patients treated with stem cell transplantation between 1996 and 2010. 72 patients required dialysis, half of them within 30 days of transplant. And look what happened to those patients. Those patients have the poorer outcome with a median overall survival of only 7 months and a transplant-related mortality of 44%. This is very high. When the risk factors for requiring dialysis within 30 days of transplant were explored, 2 factors were found. If the eGFR was less than 40, and if the serum albumin was less than 2.5 grams per deciliter. If both factors were present, the risk of dialysis was 44%. Unfortunately, these 2 risk factors are also a risk factor for progression to end-stage renal disease as part of the natural history of the disease. And the decision if whether to proceed or not with transplant is quite a difficult one. One of the options that can be considered is having an induction chemotherapy, hoping to improve the renal function and to reduce the likelihood of proceeding with to end up with end-stage renal disease. To summarize the stem cell transplant part, stem cell transplantation is an effective therapy for AL amyloidosis. However, it is limited by patient selection. It should be performed in experienced centers in order to improve outcomes, and one should consider using a bortezomib-based induction, especially in those with more than 10% bone marrow plasma cells. We are now moving to the management of stem cell for patients that are ineligible for stem cell transplantation. First, the picture for those patients is much brighter. This is the survival curves of patients that are ineligible for transplant between 2000 and 2014, divided into 3 eras. And you can see this is a Mayo Clinic data that the survival is improving, and I can tell you it continues to improve. The 2-year overall survival nearly doubled from 25% between 2000 and 2004 to 47% in the era of 2010 to 2014. The main first-line options in this patient population who are ineligible to transplant are bortezomib-based regimens such as bortezomib-dexamethasone, Cybor-D, and bortezomib-Melphalan-Dexamethasone. Melphalan-Dexamethasone is another option to consider. Melphalan-Dexamethasone was actually the first standard intensity regimen to really produce a meaningful hematological response. This was the reason that this curve actually moved upwards because of the use of Melphalan-Dexamethasone. It is given in a 28-day cycle, Melphalan-Dexamethasone at the first 4 days of the cycle. You can see the hematological response, 67%, including a very nice complete response rate of 33%. This is an effective regimen and can be used when bortezomib is contraindicated or in places that bortezomib is not accessible. However, one should consider using a lower dexamethasone dose, such as 20 milligrams a day, especially among elderly patients or patients with severe heart or kidney involvement. Dexamethasone is quite toxic and can aggravate fluid retention. Let's look at the data on upfront Bortezomib-based regimens. There are many publications on that, and I gathered here 3 of those. The European Cybor-D collaborative study with 230 patients treated between 2006 and 2013. This is the early era of the use of Cybor-D. Recently, the UK group published prospectively on over 900 patients treated with bortezomib, mainly Cybor-D, between 2010-2017, as well as the bortezomib-Melphalan-Dexamethasone arm in the study that compared BMDex versus MDex. You can see that across those 3 studies, the complete response by intention to treat analysis was anywhere between 21% to 25%. Patients could also achieve a cardiac response and a renal response, and the median overall survival across those studies was over 5 years. This is an exciting data on comparison of bortezomib, Melphalan-Dexamethasone versus Melphalan-Dexamethasone in newly diagnosed AL amyloidosis patients. This study included more than 100 patients recruited in different centers in Europe and Australia. And one can see that the overall response rate was better in the bortezomib-Melphalan-Dexamethasone arm compared with Melphalan-Dexamethasone. It was 81% versus 57%. The major improvement in response was the rate of the VGPR, 42% versus 20%, where there's no great difference in CR and partial response rates. This translated into improvement in progression-free survival and overall survival for patients treated with bortezomib, Melphalan-Dexamethasone over Melphalan-Dexamethasone. How to manage bortezomib toxicity? One should avoid the use of bortezomib in the face of pre-existing neuropathy or to use it in an attenuated dose. We recommend sub-Q administration and only as a weekly dosing. Twice weekly dosing is not recommended and is very likely to result in termination of therapy. One should consider initiation of bortezomib at a lower dose of 0.7 to 1.0 milligram per meter square in patients with severe heart involvement and increase the dose based on tolerability. This is due to the fact that bortezomib can actually be cardiac toxic in this patient population. Patients should be monitored for their symptoms and side effects carefully, including monitoring cardiac biomarker on a regular basis, just because of the fact that bortezomib can be cardiotoxic. In the emergence of neuropathy or other major toxicity, reduced dose or discontinuation of bortezomib should be followed. This is the course of a patient of mine that was diagnosed with cardiac AL amyloidosis. He initiated therapy with Cyborg-D. These were his cardiac biomarkers. You can see that the high sensitivity troponin T was at the 170 range and the NT-proBNP was over 2500. He achieved a very good partial remission by the end of the third cycle and continued with Cyborg-D. But then he developed a significant neuropathy and cardiac toxicity that was in the form of elevated cardiac biomarkers, low blood pressure, and recurrent syncopal episodes. At that time, I terminated the Cyborg-D and wanted him to continue on therapy, and he continued with the daratumumab as monotherapy. You can see that the level of response slightly went better, although he remains still in the VGPR. But look what happens to his cardiac biomarkers. There is a complete decline in cardiac biomarkers, highlighting that bortezomib was highly associated with cardiac toxicity. And here, 12 months from therapy, he had a cardiac response level and doing better. How to assess the treatment effectiveness? As we mentioned, our target of response is at least very good partial response. CR is a better response, but once again, if we achieve a VGPR, that should be probably good for the majority of patients. Patients that have a low DFLC, and this is defined when the DFLC is between 20 to 50 milligram per liter, the response should be to a DFLC less than 10 milligram per liter. One can use the serum M spike if it's present. Approximately half of the patients will have an M spike in order to assess the response, especially in those with low level of circulating light chains, in which the response is much more challenging. Moreover, patients that have renal failure, we know that the free light chains are cleared by the kidneys, and sometimes it's hard to assess the response in this patient population. Therefore, those patients at times require bone marrow biopsy to understand if they achieve a deep remission or not. When to modify or change therapy? I would recommend modifying or changing therapy if there is completely no change in serum involved free light chain after the first cycle. If a patient did not achieve a partial response within 2 to 3 cycles, one should consider modifying changing therapy, or if treatment is not tolerated. There is more and more data emerging about the depth of response irrespective of the hematological response criteria. This is data from the UK group on their bortezomib prospective study. And you can see that both for overall survival and time to next therapy, when the DFLC was lower, the outcome was better. This is a DFLC less than 10 milligram per liter. This is a DFLC between 10 to 40 milligram per liter, and in the orange curve, DFLC greater than 40 milligram per liter. Another representation of that is here data from Mayo Clinic, looking among patients that achieve at least a very good partial response. And you can see that both for PFS and OS, if the involved free light chain is less than 20 milligram per liter, the outcome was better both for PFS and OS. And actually was better when we use a more stringent DFLC at 5 milligram per liter, where there is same benefit in terms of PFS. However, the overall difference, overall survival difference was much less. I want to point out that we want to use the hematological response criteria. Those are good criteria, but you can always get further understanding of the depth of response of the patient if a patient really achieve a low levels of IFLC and DFLC. We're now moving to our last section, which is the treatment of the relapsed refractory AL amyloidosis. Our recommendation for second-line therapy is daratumumab or daratumumab-based therapy. This is because daratumumab is associated with fantastic response rates. You can see anywhere between 63% to 100%, and the majority of those responses are actually in the VGPR and CR range. The time to response is also quite fast, between 1 month to 2 months. So daratumumab is an excellent agent in amyloidosis. It can be given as a monotherapy and produce very deep remissions. It is associated with high response rate and low toxicity, which is so blessed in this patient population. The most common side effects, however, are infections. We know that daratumumab can cause hypogammaglobulinemia and does increase the risk of infections. And you can see in this study that included 15 patients treated with daratumumab, there is a high rate of infection, more than any other side effects, and those infections can be actually grade 3, 4, and even 5. Moreover, we don't know the long-term results of daratumumab, how long those remission lasts, and we need to wait for more data to emerge on that. Beyond daratumumab, this is our recommendation for third line. If a patient relapsed more than 2 years from his last therapy, one can consider repeating the original therapy. If the patient is not bortezomib refractory, then bortezomib-based regimen is our consideration. And if a patient is bortezomib refractory, then one can use MDex or LANDex. I also like to point out that autologous stem cell transplantation can be considered in the relapse setting, both as a first transplant or even as a second transplant. Immunomodulatory drugs are not well tolerated in AL amyloidosis patients. Thalidomide is poorly tolerated, there is high toxicity rate with this agent, and is not recommended. Lenalidomide has also issues with tolerance in this patient population, and the two major toxicities that are quite common in this patient population is deterioration in renal function, seen in 2/3 of the patients and can be irreversible, as well as the rise in natriuretic peptides, NT-proBNP and BNP. Therefore, in order to avoid or to manage this type of toxicity, I would recommend starting at a low dose of 5 to 50 milligrams a day. Patients that have heart involvement or elevated creatinine or elderly patient, we should use a lower dose in those patients and increase based on tolerability. One should carefully observe for fluid retention with daily weight and using cardiac biomarkers, as well as monitoring the kidney function. Pomalidomide is considered slightly better tolerated in AL than lenalidomide. This is the data on the 3 studies on pomalidomide in AL amyloidosis. I won't get into much details for lack of time, but I would say that the rise in NT-proBNP and BNP is also seen with the use of pomalidomide, and some precautions should be used when using POM in this patient population. What about proteasome inhibitors other than bortezomib? We have ixazomib and carfilzomib. This is the Tourmaline AL1 study. It's a phase 3 randomized controlled trial that just recently released its results at the ASH meeting. This was a comparison between ixazomib and dexamethasone versus physician choice that was mainly lenalidomide dexamethasone or Melphalan-Dexamethasone. This study failed to meet its primary endpoint. Hematological response, the overall response was quite similar, 53% for ixazomib versus 51% for physician choice. There was slightly higher CR rates with ixazomib compared with a physician choice. Moreover, the median treatment duration was higher with ixazomib, nearly 12 months compared with 5 months, as well as the better vital organ response rates, 36% versus 11%. However, there was no difference in overall survival as well as in hematological progression-free survival. Therefore, ixazomib may have a role in AL amyloidosis, although it must be emphasized that those patients were sensitive to bortezomib. Carfilzomib is a very challenging agent to use in AL amyloidosis. We know that 10% of patients with myeloma treated with carfilzomib will experience cardiac toxicity. It is also an IV infusion and required hydration. There was one study, dose escalating study, with nearly 30 patients in AL amyloidosis, which found the maximum tolerated dose at 20/36, lower than the myeloma population. Although the response rates were quite encouraging, look at the cardiac toxicity rate, 36%, and those are major toxicities, including ventricular tachyarrhythmias, a decrease in ejection fraction, and hypoxemia. There is a report on the safe use of carfilzomib among patients with peripheral and autonomic neuropathy, 5 patients, as carfilzomib is considered less neurotoxic. Venetoclax is another agent to discuss on the management of relapsed refractory AL amyloidosis. This is a BCL2 inhibitor. It has an activity in CLL, non-Hodgkin's lymphoma, AML, and subset of myeloma patients, mainly those with translocation 11;14. So why Venetoclax in AL amyloidosis? 2 major reasons. One, translocation 11;14 is present in approximately half of the patients with AL amyloidosis. Moreover, patients with this translocation that receive bortezomib are less likely to respond and to survive using this type of regimen. There is a limited experience in AL amyloidosis population, but recently Dr. Siddiqui at the IMW meeting has presented our early experience at Mayo Clinic with Venetoclax. This includes 12 patients with a median prior lines of therapy of 2. The vast majority of patients had translocation 11;14. The dose that was used was 400 to 800 milligrams a day. 7 patients received that in combination with dexamethasone. Of the patients that were available for response, the response rate was quite good, 87% all CR or VGPR. But you can see that 2 patients already progressed 4 and 5 months from therapy. Toxicity was minimal and there was no reports on terminal lysis syndrome. Bendamustine is another agent to consider, although in the general AL population, the response rates are not very high. The only subset of patients that bendamustine is probably worthwhile considering is those patients that have an IgM AL amyloidosis or patients with a lymphoplasmacytic histology in combination with Rituxan, bendamustine Rituxan, and you can see that the response rates are better, 58%, 59%, including VGPR rate or better of 20 to 50%. So in summary, early recognition is the most important factor to alter disease course. This always needs to be emphasized. We need to diagnose those patients earlier. That will give them a better chance for survival. Treatment should be guided by stem cell eligibility. In standard intensity therapies, bortezomib-based regimen is the current standard. response and toxicity evaluation should be performed on a monthly basis. We need to know if the patient is tolerating the therapy and if it continues to respond. But if it's not, we need to change our therapy. Goal of therapy is achievement of at least a very good partial response. And in the relapse setting, the most promising results are seen with daratumumab. I would like to highlight my colleagues here at Mayo Clinic Rochester who are involved in the complex management of AL amyloidosis. You can see that this includes providers from hematology, nephrology, cardiology, neurology, as well as lab personnel. I thank you for your attention, and I'm ready to answer any questions that you may have. Thank you for joining and listening for this webinar on the management of AL amyloidosis. Okay, I have just put the lights on. Okay, so we have the lights back on. I have one question that I want to ask and answer. So, how long should the therapy be continued in the AL population, especially those that are transplant ineligible? Well, we don't have much data about that, but I would say that this really depends on the kinetics of the response and the risk of disease relapse. In patients that have a low tumor burden and do not have high-risk genetics and achieve a very good response at the initial phase of therapy, I believe that probably 6 cycles of therapy is enough, especially if the deep response was achieved early on in the treatment course. Patients that have a higher bone marrow plasma cells or have high-risk genetics, we probably should pursue therapy for a longer period of time. We know that patients that have high-risk genetics, as well as patients that have a higher tumor burden, are more likely to relapse, and we want to make sure that the therapy that we gave them is associated with a durable response. This is always when we need to consider the tolerability, toxicity, and patient desires. But as long as we can assure that the patient is in a deep response and for a durable time period, I think this will be my goal in determination of the duration of response. I would also like to highlight that patients that's been observed off therapy, we need to watch for them for probably at least every 3 months. We want to intervene early on when the disease recurs than letting them progress and result in further organ deterioration. It is also likely that patients that have cardiac involvement, the threshold for therapy should be lower, as those patients can experience significant organ deterioration, and we want to prevent that by early intervention, especially as today we have a much more better therapies than we had before. Okay, there are no further questions at this time point. I thank you for all who joined this webinar, and I will end this session here, and thank you very much. Good day.